Kerry. Okay, we now have Dr. Kerry Kuluski, thank you, to speak. Kerry is the Dr. Mathias Gysler Research Chair in Patient and Family-Centered Care, Institute for Better Health. She's also an associate professor at the Institute of Health Policy, Management and Evaluation at the University of Toronto. Kerry will take your questions at the end of the presentation. I will help with those as well. So everyone, please welcome Kerry. Thank you. Would you like the mic?
I think I'm good with this, yeah.
Great.
How is everybody doing? I'm taking notes on facilitation because just putting your hands out, moving your fingers, doing a little shake, it just really helps to re-energize as we move into this next chapter. But big thanks to Rob for really setting us up well to really dig into a really, really good discussion today. And if I were to sum up this talk into 2 words, so this means you can, please don't fall asleep after this, but if you fall asleep, remember these 2 words: collective impact. We can't do this alone. We can do so much more together than we can do independently. We all need each other to really focus on these complex problems that we're facing, put our heads together, and really understand more deeply how we can solve these challenges together. So remember, collective impact is the term for today. So a little bit about me. Often I get caught up in accomplishments, titles, this and that, but when I really think about who I am, I'm a Northern Ontario gal. I have strong working class roots. My mom emigrated from Poland, taught me really strong values, a strong work ethic. I eat lots of pierogies. Any Polish people in the audience? Woohoo! Yeah, it's wonderful. And the Polish culture has been a really big part of how I've grown up and having a strong community, strong family, and learning those traditions. Another recent experience that I had, though, that came a bit unexpectedly was a patient experience. And I used to go just for routine, health checkups. And during one of those checkups, I found out that I had very high blood pressure, which I didn't expect, and it stayed high. And that then set off a pathway of specialist visits, cardiologist visits, and an integration into the health system and use of medication way earlier than I ever thought I would be on medication. And in this experience, I had good care, good access to primary care, and fast access to specialists, but I also had care that could have been a lot better. Experiencing confusion, not understanding what's going to happen next, not understanding the symptoms I was experiencing, and I finally had a better understanding of the thing that I study. When you have that personal experience, you can bring more richness to the work that you do. And I know it pales in comparison to many of the experiences that the patients and families have had here today, so I wanted to acknowledge that. But it provided a glimpse into the system that I had never seen and experienced before, and it's changed how I go about my work. So, and of course, I had to put any cat people in the audience. I'm sure you noticed her. Anytime I'm on a Zoom call, it's Squeaks that is stealing the thunder. But, she's also an icebreaker. She's a community builder, because when I'm meeting new people online, it's often, oh, you have a cat. And we start talking about our pets and our animals, and it creates a space to create a connection and start a conversation. So she's actually secretly this community builder, and I think we have a lot of that in our lives. And so today, I really want to highlight the fundamentals of engagement as being all about relationships. It's all about connection. It's about how we connect with one another. We'll take a person-centered approach to learning health system. I'm going to break down the gears that Rob showed and talk about how we can really apply person-centered principles to the learning health system approach. Then I'm going to dig into a very specific example about some work that we're doing at Trillium, where we're changing how we collect experiences from patients and using that to inform how we do care at the front lines. And so I'll walk through the learning health system with that example, and then talk a bit about how we can sustain patient, caregiver, and community engagement when things get tough, drawing from some lessons from the pandemic. And so when we talk about engagement, we often kind of think about it initially as an activity, which it is. So we do co-design work, we get around the proverbial table together, we roll up our sleeves and we try to create something together. But it's really another definition for engagement. There's a democratic definition that people have the right to have a say in what happens in the healthcare system, what happens to them. I think everyone in this room probably believes that, but to an earlier comment that we heard from someone in the audience is not everyone will believe that people have a right to have a deep say in what health systems look like, and that's what we need to shift. It's also, there's a narrative definition to engagement. It's about learning, unlearning, challenging each other, really owning our biases, and being able to put some of our own agendas aside to really learn together, work together, and build something that we can't do alone. I love this quote, and I need to read it. Relationships, and I use this in a lot of my presentations, are the essence and fabric of collective impact. What's critical for those who facilitate collective impact efforts is to support relationship development in ways that build true empathy and compassion so that authentic connections happen, particularly between diverse participants. These deeper connections can form new avenues for innovation to address the social problems at hand. So we can do way more. We can really, when we can connect and build trust, we can really do a lot more together that's far more creative. And I think what we're up against is a system that is quite static. We like nice, neat, and tidy measurement tools and frameworks, which kind of keep us in a box. And really, we have to move outside of that for complex adaptive problems because they defy the tidy logic models and the reductive technical solutions. So it's time to invest in that collective energy to really honor and focus on transforming relationships, or transforming systems through relationships. And so technical versus adaptive, a little bit of business literature I'm pulling from. But when we think about, when are we going to apply a learning health system, it's not to everything. There's certain solutions that exist, these kind of technical problems that have neat and tidy technical answers. So maybe best practices for certain conditions, surgical checklists. There's certain things that are tried and true, expert-driven, they're implemented and no one questions it. And that's fine. So we leave that. The adaptive problems that we face requires many people with different backgrounds, patients, caregivers, providers, system leaders, community members, researchers coming together to bring our collective skills together to think and do things differently. And we might resist this because it's uncomfortable. It means that we have to be vulnerable. It means we have to work sometimes outside the scope of how we've been trained to really kind of take down those barriers and learn together. And so what happens sometimes is we'll try to slap on a technical fix to an adaptive challenge. And a key example of that is when there's a shortage of bed in hospitals, what do? We add more beds, and we think that's going to solve the problem. But we're not thinking about how can we tackle this from a system perspective, focusing on prevention, looking at solutions outside the walls of the hospital. That would be an adaptive fix as opposed to a technical fix. We need the learning health systems to move from technical to adaptive. When we think about what does this mean for engagement, and I think a lot of us, and I strongly bring the researcher perspective here, that typically what we do, and I still do this, we get funded to do a project, and then we either rely on the people that we've worked with before. We might have one or two partners that, they have relevant lived experience to the topic. It's very time-bound. The funding runs out, and it's over, and we hope that we can stay connected and keep the relationship going, until we get more funding. In a learning health system, we can start to think about how we have a more continuous relationship across the system where we continue to work together, because in a learning health system, you're never really done. You're going to implement something, and as Rob said, it's not going to work the first time. It probably won't work the second or the third time, but you're continuing to make those adaptations, and you continue to do that with your community, so you're always working together. And it doesn't mean you'll always work with the same people forever and ever, but it's about building that community that stays connected and evolves together. There's a paper by Knowles in Health Expectations that talks about person-centered learning health systems. And the way they broke it out, and this was a product of co-design sessions that they did in the UK, they talk about attitude, access, and action. And the attitude piece aligns with the democratic form of engagement, where you really believe that the answers to a lot of our health system issues lies with patients, caregivers, and community. Everyone, depending on your role, will have part of that answer, but it's really believing that they need to be part of that conversation and part of developing the solution. Access is around transparency, about where the data is coming from and how they can have a say in terms of the direction of the research and the impact of the work that they have. Instead of doing a co-design activity and saying, thank you for your time, and not ever looping back to talk about what the impact of that work was. And also action, so for people to really understand, all partners, the impact that they've had with the work that they've done, and what it means for the system, and how it's changing the system or not. So that transparency piece. And so going back to the gears, this will look familiar just from Rob's presentation, there's some key questions we can ask ourselves at each of these stages, each of these gears that we see if we want to be person-centered. And one big piece when it comes to data is asking who's represented in the data that we have. We'll have some information, but we're not going to have necessarily the rich experiential data that we would get. So we may want to do interviews and then try to create the space where people feel comfortable to share their experience through interviews or through different engagement activities. And if you're partnering and going to a community, asking yourself, are you going there and extracting information, which we can easily do, or are we building a relationship and figuring out with the community what are those important questions that we need to ask, and then how do we work together as a result of that? So, you know, the first part of the learning health system is really framing the question that you're going to tackle, looking at the problem that you're going to solve for, and the community can play a role in helping define what that looks like. When it comes to evidence, it's asking, well, it's important to look at what's been done elsewhere if you're looking at solving a particular problem, but also looking who's represented in those examples and who's missing. So being mindful that it will give you some idea of where you can focus your efforts, but you really need to understand like what's present and what's missing in that literature. When you move on to your co-design activity, really asking yourself who is present, who are you working with, and who is missing? And are there other ways to connect with those communities that aren't working with you presently in that co-design activity? So trying to get different perspectives and the relevant perspectives to the questions that you're looking at. Also, when you're implementing your intervention, keeping in mind of who will be able to potentially access this and who won't. Where is this situated? So what are sort of the nuts and bolts around what that looks like? And then also, are we measuring things that matter to people? So when it comes to the evaluation and adaptation piece, even though I'm showing this piece last, it's important to think about this piece right from the beginning. So when you're building your team and working with your community, thinking about, what kinds of things do we want to measure? What really matters to all the different partners that you're working with? So what matters to patients? What matters to families? What matters to care providers and leaders and researchers? And reaching some consensus on how you're going to focus that work. And also tailoring your implementation and evaluation so you could really understand what works for whom and under what conditions. Because you might co-design something with a particular community or group of individuals, and it might work well for them, but then deepen inequities for other community members if they haven't been considered in that work. So case example, putting person-centered care into action. So is this a relatable quote? Yes, I keep telling my story, no one's listening. I have to say, this was probably the first 10 years of my career. I did tons of interviews, tons of patient experience work, and finally people said, this is great, but I've been telling my story for decades. When are you going to do something about it? And then realizing, having an aha moment, we need to figure out how we can respond to all the experiences that we're hearing about and actually have a system in place that could then create some change for the stories that we're hearing. And granted, we hear the good, and we also hear the things that might not work quite so well. A big fan of Angela Coulter from the UK, and the way she would want to solve this problem is acknowledging that we have multiple ways to get information from people. We need to figure out how to synthesize that information and then use that information for system change and really bring it down to that quality improvement, learning health system space where we're actually responding to the data that we have. And so what we often do is we want to boil the ocean. We want to do all the things. So we might figure out what the problem is that we want to solve, but then how do we decide how to respond to that problem? So I'm going back to my nerd multiple streams policy literature here. And the problem that we're going to focus on for this presentation is we don't incorporate patient experience data into planning. So there's a number of ways we can respond to that. So there, you can see there's 3 streams. There's the problem stream, there's the policy stream, that's how we can respond to it. But then there's the politics, like what's actually going to land? What's actually going to, like what's the timing for this? How do we move this along? So the policy could be, we could revamp the survey strategy, we can do community engagement activities, we can create dashboards, we can do focus groups, we can really do a whole number of things. And I remember presenting this to senior leadership, and Rob was there, and I had like 100 different slides with all these details of all these things we can do, and the chief of staff was like, no, come back when you have a plan, an idea that's crisp, in like 2 to 3 slides. Like, okay. So I really had to think, how do I position this? And I thought, how can we be opportunistic given the climate that we're in right now? Because not everything that we want to do is going to get taken up. And so the politics stream is I looked at, okay, so what's in our strategic plan? Like every hospital, we said we're obsessively patient-centered. I'm like, okay, so I have that down. We need to act on patient experience data if we say we're obsessively patient-centered. But we had accreditation coming up. And accreditation in Canada is looking for concrete examples of how you're being person-centered in the work that you do. And the big ticket was our survey vendor was expiring. And so we had a chance to change how we capture information from patients and families and do it in a very different way, because big surprise, the 80-something questions that a random person would ask when they called you on the phone, people didn't answer. Shocking. That was our strategy before, and I thought we can only get better. So because we knew that focusing on surveys would not be enough, but we had this window of opportunity, given the climate of the organization and the system, to push that through initially as the first step to then doing something broader, right? So yes, surveys is a bit limited, but it's that first stage of a much broader engagement strategy. And so going back to the years, this is what we did. So before we changed our patient experience survey strategy, we looked at what we had. So we didn't have a lot of data. We didn't know who was represented in the data. We didn't have a sampling strategy. But we knew that we had a very diverse community. So Peel region, where Trillium is situated, is a very, very diverse community. It's kind of like a microcosm of Canada in one community. And we didn't really know if they were actually represented in the data that we had. So we knew we had to consider that as we evolved our strategy. We did a scoping review, so there's a second stage of the learning health system, and realized that a lot of hospitals were struggling with how to best mobilize that information and use it for system change. But there were some examples out there that we looked to that seemed to work well that I'll share. And so what we landed on was a new patient experience strategy with just 8 to 9 closed-ended questions and open text, which is so powerful, because we could use Text IQ to then filter through all the open text and look at positive and negative comments, which could then guide how we focus our quality improvement. And we're getting 600 survey responses every single week. So now we're drowning in data, and we have to figure out what do we do with it to create that system change. So we've rolled out the new survey strategy, an 8-fold increase from this time last year across the emergency department, inpatient, outpatient, pediatrics, and adult inpatient and outpatient. And we've created dashboards, we can link it to clinical units, and now we're trying to figure out how do we infuse it into clinical workflows so it's used in day-to-day practice, so it doesn't feel like an add-on for staff that are extremely burnt out for very good reason. And so in the future, because that's the stage where we're at, that implementation stage, we could evaluate, are people, clinical units, using patient experience data for changes on their units? And if they do, does it improve outcomes in patient experience? And that's the big question that we're going to be looking at over time. So now, the new problem, as I said, we have over 50,000 patient experience survey responses, and they have a lot to say. But what's really cool about this is we're getting lots and lots of positive comments, and also lots and lots of comments pointing to what we need to improve. This first quote, and I pull this out, and it's good that there's names here, because Janet in the emergency room knows that she made a difference. Because when this was presented to the manager in the emergency department, he went to Janet and said, "Thank you for the work that they're doing." They have rounds every week where they pull positive patient experience comments and they share that as a team. Because they are frustrated, they're burnt out, moral distress is an all-time high, and to hear what they're doing well helps them go to work the next day. And that's a big learning, because as a researcher, we often have a deficit focus. What's going wrong? What do we fix? How do we change things? But we can really learn what's working well. And having the open text data will give you richness, because we ask what's working well, what can we improve? Two very simple, straightforward questions. We're getting tons and tons and tons of data. On the other hand, we also know, like, where there's certain units where, something's happening. Is it burnout? Is it what happened that day on the unit where someone felt neglected? And there's an opportunity to have a conversation to learn. How do we learn from that and work together? Interestingly, one takeaway, text data can give us lots of insight on what to improve. But what's interesting? We get so caught up in the 0 to 10 scores that we might be like, yay, 10 out of 10, this is great. But satisfaction doesn't equal experience. So this person gave a 10 out of 10. Said, perfect. But then given the opportunity to elaborate, they said, discharge was a bit sloppy. Nurse had not been my nurse that discharged me, and she was quite uncertain about me and what she should be doing. So I always use examples like this, because I find what happens is people get caught up in the metric. And for sure, there's examples where there's 9 out of 10, 10 out of 10 in positive comments, but lots of examples where if you just peel back the onion a little bit more, you get lots of answers. It's like seeing someone in the hallway. How are you doing? Fine, fine, everything's fine. But we sit down with a friend and they said, how are you really doing? Then you get the answer. So how do we do that for patient experience? And the open text is providing this little window to have that sit down of how is it really going, where you can learn and then move forward from there. We've taken the open text data because whether people feel emotionally supported is our biggest driver in experience. Scores are high if people feel emotionally supported. Scores go down when people don't feel emotionally supported. So we took the open text data and created these statements of what patients want. Explain things clearly. Make it easier for me to get around. Let me have my family here. Speak to me like a friend. Make sure I'm okay. Learn about me as a person. Keep my environment clean. Tell me what is going to happen next. Ask me what I need to allow me to feel safe, and check in with me. Thousands and thousands and thousands of responses, and we could solidify into these statements. This is what we need to do to improve emotional support in our hospital. Another takeaway is the co-designing the engagement is always ongoing. We're continuing to tweak and adapt and think, how do we reach more communities? How do we really understand what's happening? How do we advance this patient experience strategy? So we've been engaging with different communities to learn how to do that. And also, when we're asking these questions, we have to consider how we engage and collect information, because that really matters. And so we did a study with our community members, patients, families, leaders, and providers, and they cautioned us. They said, you can't just send out a bunch of surveys. You really need to, and this really came from the patient caregiver population, communicate a clear purpose. Tell me why you're collecting this information. What will you do with this information? So really forcing that accountability. Creating the psychological safety. So creating the spaces where people feel open. It's like that how are you conversation. How do we create the space where people can elaborate and say, actually, there's things that could be better. How do we create that? Learn throughout the patient journey. So we're famous for this in healthcare, is that people get a hospital experience survey, they get a primary care survey, they get a home care. How do we then create those connections so people can really speak to their full journey? We need to acknowledge that people want to share in very different ways. So people might have different types of abilities that allow them to share in specific ways and not others. People might prefer to have an interview than to fill out a survey. You know, we have to have those considerations in place so we can really get multiple voices to the table. And also, as Rob said, focusing on people who aren't coming to the hospital or coming to our setting. So getting community level data, understanding the needs, more of a population health focus, the needs of people that we currently don't see, and understanding what they need so we can plan for the future as well. So very quickly, this quote, this healthcare professional who was part of the study I won't read the quote, but basically said, like, you know, surveys clearly aren't going to work for everyone. We have to consider the histories that people have had and the reluctance maybe to share data and to share experiences. And we need to have a much wider approach in terms of how we collect and you know, use this information and engage with populations. So always learning, you know, as we do this. Takeaway 4, it takes a village. How do we put this into action? And I'll very quickly hit on some research that was done in England in the NHS, and they looked at what teams, they looked at 6 different hospitals across the NHS, and they did ethnography to see what are these teams actually doing when they actually look at patient experience data and act on it. And there's different types of capital, so I'm pulling on Bourdieu's sociological construct of capital. And they noticed that when people are actually using data for quality improvement, there's a lot of cultural capital. So they have lots of different people from different facets of the organization, so a nice range of knowledge and skills to sense make with the data that they have. They have economic capital, so they have access to resources. They have social capital. They feel valued, connected when they're working together. Symbolic capital, so involving people that have the power to make the changes, so leadership level. And their big finding, which adds to all these constructs, is team capital, and that's the range of people. It's not just the quality improvement team, it's the patients and the families and the providers and the researchers and the organizational leads coming together to solve complex problems, so that team capital will help to move the dial. And very quickly, so at Trillium, similarly, when we ask people, how do we move this into action? They said we have to adopt a learning culture and time for sense making, because we're just, every day is like a giant game of, you know, that whack-a-mole game? We're just trying to get through the day as we respond to the various things that happen. How do we take that time to pause and really think about with intention, what do we need to do next? So it's not a one-person endeavor. It's not one department. It's not one group of individuals. We need to collectively address this. Co-designing with patients, caregivers, and communities. And finally, really showing the responses to the feedback that we get. So I'm going to skip over this. And I think I will end with this quote from a patient partner that we've worked with quite closely. And this really hits the nail on the head, for me in particular. And he said, you know, to be able to be honest and vulnerable and not get into, I'm the expert here and you're not kind of situation, that's true empowerment. When you're like, I'm listening to this voice, I'm hearing it, I'm giving it the space that it needs and incorporating it at the fundamental level of how it's designed. So I think I do have one quick slide in my last 30 seconds. So what do we do when it gets hard? COVID happened. We did case studies all across Canada to learn how are organizations adapting and pivoting their engagement efforts. Why did some organizations continue to engage with communities, patients, and families, and others didn't? And we found some core things, so strong, people that have a strong history of doing this work. Clearly that makes a difference. But they all started one unit, one team, and they grew from there. So people that had that history, it was easier to keep things going. People that had strong linkages between organizational leadership and patient and family partners, like having conversations, sitting at tables together, solving problems together. Giving patients and caregivers the space to lead, sometimes stepping aside and saying, community, you have the answer. How do we do this? How do we honor that and commit to that? Having meaningful activities and creating new avenues and spaces for engagement, including, like, technology doesn't work for everyone, but it's really helped to open the doors for others to continue to engage. So as we move forward, just to close, thinking about ecosystems of engagement, moving beyond, I gave some very specific, like, institutional hospital examples, but how do we kind of widen the tent to look across all the different communities, all the different health and social care sectors, to really honor the knowledge that exists across our very large ecosystem, which is full of stars, full of knowledge, and have the answers to some of the problems that we face. and then using a distributed leadership model to really honor the knowledge that we all bring from all of our past experiences and the various hats that we wear. So finally, 3 key takeaways. Collective impact efforts must prioritize working together in more relational ways to find systemic solutions to social problems. Look for those windows of opportunity to strategically drive your ideas forward to see change. We can't boil the ocean. And learning health systems that are person-centered can lead to more meaningful systems change. So I will leave it there, and stay tuned and a couple of patient partners are here today that helped support this document. We have a public-friendly version of the learning health system coming out, so we could explain it, because I still struggle to explain learning health systems. In a much more public-friendly way, we engaged with 13 patient and caregiver partners from across Canada who has helped us figure out how do we describe this, how do we then share it with the public to ignite more excitement around involvement in health systems. There we go. Thank you.
Thank you so much, Kerry. I mean, what I got from that, the words that really stood out to me was impact, connection, audience, engaging, purpose. How can we start with ourselves? And it made me think about our improv mindset and how this is a nice bridge. One of the improv mindset tools that I said at the beginning was how can we inspire our audience? And you're talking about reaching out. And one of the things I feel, and I'm going to steal this from one of our communication programs, is starting with ourselves. And one of the things that we can do is maybe look at our mission statements. Like, in my role, I exist to. And when is the last time that we wrote a mission statement for ourselves? This is then to inspire and then activate ourselves into sharing our mission and inspiring our audiences. So think about that over the next few days, few weeks. In my role, I exist to. Okay, wow, thank you so much, Kerry. So we do have some questions online. I'm going to go for the most votes, so get your votes in. And if I can't see any, I will go to the chat as well. We have around 5 minutes for questions, and we have some audience. I'm going to let this lady actually take the floor because I did. Yes, I said I would come back to you, and I did it, and here we are. So take it away, please. Thank you.
So, Kerry, that was wonderful. Wonderful presentation. I really applaud your work. My name's Carolyn Canfield. I'm a patient partner here in British Columbia, but wider across Canada and internationally as well. So when we're talking about learning health systems, and we're talking about the patient and community as being one component of those three, the three-legged stool that Maureen Smith described. It's a shorter leg, it's a diverse leg, and it doesn't have the capacity to build the interactions that would support that longitudinal relationship. And the question I have for you is, because we don't fund a collective learning and knowledge exchange among patient partners in this room, or across Canada, or internationally, and we have a barrier at looking at the evidence because patient partners can't access peer-reviewed journals, generally. What can we do about the criticism that our patient partners look like me? They're people who have time on their hands, who are able to participate in a 10 o'clock in the morning meeting, who have the technology and so on. There's a big drive for diversity, for accessing the communities who most rely on our health system. How do we get over this barrier, get over this bridge of having patient partners in research who have participated in previous research projects, who have been able to learn about research from researchers, who have that privileged position in the research community? So do you have some ideas about how to build in durable relationships with vulnerable communities? Thank you.
Thank you. That's an excellent question. And as a research community, we're starting to shift, myself included, in terms of how we connect with communities. Because typically what happens is you apply for your grant and you're like, okay, now I need some patient partners, and you have the usual suspects that will come to the table and partner with you. But there's other ways to approach this, and it takes time because it's about building relationships, and it's about community-based participatory methods. If we use a research term, it's about going to the communities and showing up as a partner, not showing up with, I need this, I need that, I want you to be on my team. It's showing up to the different community organizations that are serving diverse communities, showing up as a listener to learn what's important to them, what's the conversation, and is there a connection here to be made? And to be quite frank, I found that intimidating individually because where do I even start? I can't just show up. But there's individuals that I think of that they're community connectors. So they're people that are already embedded. They're people that are within maybe the networks that we have that could then foster that bridge to be that person that then connects you into that community. So you're not showing up as a stranger. You're coming through a trusted partner, and then you show up as a listener and start to build that relationship. And there's several scientists at the Institute for Better Health that have been really good about being on community tables in our region, and then have been my bridge to then reach out to get a broader group participating in research. And because of that, we're able to increase the diversity of the participants that we're working with. We're not reaching everyone, but it's certainly a lot better than traditionally where you have people that have the time and the resources to show up and be part of that. So look for those community connectors, show up not with an ask, but with curiosity, and start to build those relationships. And then from there, you're starting to expand the connections. But you could work with the partners you currently have, and they could also help to be the bridge to that as well, including patient and family partners, to your point. So thank you for that.
Thank you, Kerry. I'm going to come back to you, kind sir, but I'm going to ask one of these questions first. I will do my best to pronounce words correctly. Were you able to capture any disaggregated patient experience data on dimensions of diversity to look at experiences, equity, deserving groups? And what are some ways, that word, can you do that word for me?
So to examine disaggregated?
Disaggregated.
Yeah. You did a great job.
There it is. Thank you for Dr. Kerry. I wouldn't want to do without
Took
you.
me a second too.
Yeah. So data might be included to examine patient experiences for diverse patients.
Such a good question. So when we were revamping our patient experience survey, Rob and I said we absolutely need some socio-demographic questions so we can disaggregate the data and look at subgroups. And so I have to tell you, so if we look at our overall patient experience score for everyone, for inpatient, it's like 8.9, it's looking not bad out of 10. But then I pulled out people that identify as Indigenous, Métis, like all the different categories for Indigenous populations. It dropped significantly. So we start to see for inpatient experience, it changes. And so also for our Arab population in the emergency room, same thing. The scores, you start to see them come down. So we can't just put everyone into one group and say, yay, we have a great metric, or we're doing a great job. You have to really look very specifically at different age groups, different backgrounds, different socioeconomic statuses to see where do we really need to focus our efforts. And then what you can do from there is look at your open text data to say, what are these different populations saying? And then you could tailor your quality improvement activities for that. Or at the Institute for Better Health, we could launch a study to say, we want to understand people that identify as Indigenous, we want to understand their experiences, and we're going to go to their communities to better understand what they need and how we can create a hospital that works better for them. So that was a really great question. Thank you.
Thank you so much, Kerry. We're going to have this gentleman comment or question from you, kind sir.
Just a little history of myself. Pat O'Connor,
Hi, Pat.
patient partner. I've been diagnosed with chronic kidney disease, with macular degeneration, with psoriasis. I've had a quadruple bypass, and then a year and a half later, stents. And then after the stints, I lived with angina for 3 years, having to wear the nitro patch, taking the nitro spray, needing 2 naps a day, morning and afternoon. I became a vegan in 2012, and all that is now history. Where is that in our research and efforts? Because it's being peer reviewed. It's out there in the literature. I asked my cardiologist, why didn't he tell me I could reverse my heart disease? He said, well, most of my patients wouldn't have done what you did. Patients have to be given the choice. And we have to be told that there's better outcomes out there if we do this or that. And at present, that's not being done for the most part. Thank you.
Thank you, Pat. I'm going to actually come down to one of the questions here on the app. With hundreds of survey responses every week, how do you effectively feed back free text responses within a learning health systems? It seems very rich but challenging to manage and organize.
It's an overwhelming amount of data, and what's interesting with the technology that we have, which has like the AI capability that's embedded, we can quickly organize the open text data into, we can do it through different keywords. We can look at positive comments, neutral comments, negative comments, and then what we do is we organize it onto a dashboard, and the managers across the different programs at the hospital have been trained and learning how to access these dashboards. The challenge is that some people are very keen, they're looking at the data every day, they're talking about it in huddles with their care providers that they're working with, and others are not doing anything with the data. And so we've actually applied for research funding to try to unpack that, to do case studies. Actually, it's in partnership with BC, looking at your DART data system, which is very similar to our Qualtrics data system, where if we get funded, we'll do multiple case studies across the 2 provinces to better understand what does it take to use the data for quality improvement, and what gets in the way so we don't run into the problem where you have hundreds and hundreds of responses every week and they're just sitting there and you're not doing anything with it. So hopefully through additional research dollars, we can start to address that.
Okay, thank you so much, Kerry. Talking of hundreds and hundreds of responses, we have many questions that we really do want to get to, but I would love to gift you with a little bit of a stretch break, a little bit of a breath break. So we're going to give Kerry a round of applause for being up here with us today. Thank you so much, Kerry. Thank you. Okay, everyone, before we leave our seats, there's just a couple of things I would love to run by you before we leave here. So starting at 10:30, we have our 4 interactive sessions. We have the solutions room, I beg your pardon. We have the ideas and innovations room. And we have the learning health systems in action. And then finally, we have the presenters that will be ready to discuss their posters at the designated times. There are 2 sessions based on those themes. The interactive sessions will end at 12:45, and then that will be followed by lunch, and we'll meet back in here for 1:45. If everyone could just take a real deep breath with me and release. And please go take a little stretch break and then participate in the sessions at 10:30. Thank you.